The fluorescent lights above me hummed their monotonous tune as I pressed my stethoscope against the chest of a man who smelled like industrial cleaner and stale beer. His breathing was shallow, erratic. The emergency room buzzed around us. Nurses calling out vitals, monitors beeping in syncopated rhythms, the distant wail of an incoming ambulance cutting through the controlled chaos. "Noah, you're wasting time on a drunk janitor when we've got a multi-car pileup coming in." Dr. Marcus Chen snapped from across the bay, his voice sharp with impatience. He was a third-year resident, confident, experienced, the kind of doctor who'd seen everything twice. But something in the way this man's pupils reacted to light didn't sit right with me. Something in the tremor of his left hand, the way his words slurred not with intoxication but with something deeper. I looked up at Marcus, then back at the janitor slumped on the gurney, his maintenance uniform stained with what everyone assumed was evidence of a rough night. "I want a CT scan," I said. Marcus laughed. Actually laughed. But what I saw in that scan 2 hours later wasn't just a drunk man sleeping it off. It was a ticking time bomb that had been counting down inside his skull for days. And if I'd listened to Marcus, if I'd dismissed him like everyone else had, he would have died on a bathroom floor before sunrise. This is the story of how I learned that the most dangerous assumption in medicine isn't about what you know. It's about what you think you already understand. My name is Dr. Noah Reyes, and I'm 4 months into my residency at Hospital St. Halstead. 4 months of sleepless nights, endless rounds, and the constant weight of decisions that could mean life or death. 4 months of learning that medical school taught me facts, but the hospital teaches you judgment. It was a Thursday night, or maybe early Friday morning. Time blurred together during the overnight shifts. The ER had that peculiar energy it gets around 2 a.m., when the late-night chaos begins to settle, but before the early morning emergencies start trickling in. The kind of lull that makes you think you might actually get to sit down for 10 minutes. I'd been rotating through emergency medicine for 3 weeks, and I was starting to understand its rhythm. The adrenaline spikes, the quick assessments, the constant prioritization of who needs you most urgently. It was different from the measured pace of internal medicine floors, where you had time to consider, to reflect, to build relationships with patients over days. Here you had minutes, sometimes seconds. The emergency department at St. Halstead was a sprawling space divided into multiple zones. The trauma bays occupied the center, large open areas with ceiling-mounted equipment and direct access to imaging and the operating rooms. Around the perimeter were the individual treatment bays, separated by curtains or sliding glass doors depending on the level of privacy needed. The psychiatric holding area was tucked in a corner, designed for safety. The pediatric section had colorful murals and smaller equipment. And throughout it all, the central nurses' station served as command center, where doctors, nurses, and support staff coordinated the controlled chaos. I'd learned to navigate this maze quickly, learned which nurses knew their stuff and which ones needed more guidance, learned which attendings wanted detailed presentations and which ones just wanted the bottom line, learned to grab food when you could because you never knew when the next chance would come. Dr. Chen was my supervising resident for the night. Marcus was brilliant, everyone said so. Top of his class at Johns Hopkins, photographic memory for drug interactions, could intubate in his sleep. He'd taken me under his wing those first few shifts, showing me how to read an ER like a book, how to spot the real emergencies hidden among the worried well and the frequent flyers. Trust your instincts, but verify with data, he told me during my first shift. And learn to recognize when you're looking at someone who needs a doctor versus someone who needs a social worker, a sandwich, or a ride home. It was good advice, practical, the kind of wisdom that comes from seeing thousands of patients, from learning to manage your time and energy in an environment where both are always in short supply. Marcus had a way of moving through the ER that I envied. Efficient, decisive, never second-guessing himself. He could glance at a patient and know within seconds what needed to be done. EKG for the chest pain in Bay 3. Discharge the ankle sprain in 8 with crutches and follow-up. Admit the pneumonia in 12. His clinical gestalt was legendary among the residents. But I was learning that confidence, while essential, could also be dangerous. It could make you stop questioning, stop looking deeper, stop considering the possibilities that didn't fit your initial impression. The nurse's station smelled like coffee and antiseptic. I was charting a chest pain case, negative troponins, probable anxiety attack in a 28-year-old grad student, when I heard the commotion near the ambulance bay. "Sir, you need to calm down. Sir, please, we're trying to help you." I looked up to see 2 paramedics wheeling in a stretcher with a man who was actively trying to stand up, his movements uncoordinated and aggressive. One of the paramedics, a woman I recognized named Lisa, was trying to keep him from falling off the gurney. "Found him passed out behind the dumpsters in the service alley of Preston Building," she called out to the triage nurse. Building security called it in. Strong odor of alcohol, responsive but combative, no visible injuries. Vitals stable, but he's confused and disoriented. The man was in his 50s, maybe early 60s, wearing a maintenance worker's navy blue uniform with a name patch that read Gerald. His hair was gray and unkempt, his face weathered with deep lines that spoke of years spent outdoors or in harsh conditions. His uniform had stains on it, dark patches on the shirt that could have been anything from machine oil to spilled drinks. "Let me go," he mumbled, his voice thick. I gotta finish the floors, doctor." Chen appeared beside me, glancing at the incoming patient with the practiced eye of someone doing rapid triage. He watched Gerald try to sit up again, watched him nearly topple sideways before Lisa caught him. "Drunk and disorderly," Marcus said matter-of-factly. "Lisa, what's his BAC?" "We didn't run one in the field, but you can smell it from here," Lisa replied. "Security said he's one of the maintenance guys from Preston Building. They've had issues with him before. Apparently he's been warned about drinking on the job." Marcus nodded, already moving toward the computer to enter the basics. "Get him in Bay 7. Banana bag, let him sleep it off. Social work evaluation in the morning. Noah, you can handle the intake if you want the practice, but don't spend too much time on it. We've got that pileup coming in from the interstate." I heard the distant sirens growing louder. Multiple ambulances. The charge nurse was already mobilizing the trauma team, and I could see Dr. Patricia Okoye, our attending, emerging from her office pulling on a fresh pair of gloves. Dr. Okoye was a force of nature, a veteran emergency physician with 15 years of experience who'd seen everything the city could throw at an ER. She was known for her calm under pressure, her teaching style that was demanding but fair, and her absolute intolerance for sloppy thinking. If you presented a case to Dr. Okoye, you better have your facts straight and your reasoning sound. Gerald was wheeled past me toward Bay 7, and I caught a better look at him as he went by. His eyes were half closed, and he was muttering something I couldn't make out. The smell of alcohol was there, unmistakable, mixed with sweat and cleaning chemicals. Everything about the presentation said intoxication. Public intoxication wasn't uncommon in our ER. We saw it nightly. People who'd had too much, people self-medicating depression or anxiety, people with substance use disorders who'd lost control. The protocol was straightforward. Monitor vitals, keep them safe, let them sober up, connect them with resources. I should have just followed Marcus's lead. He had the experience. He'd probably seen 100 cases just like this, but something made me follow the stretcher to Bay 7. Maybe it was the way Gerald's left hand had trembled differently than his right when the paramedics lifted him. Maybe it was the quality of his confusion, not the belligerent argumentativeness of someone drunk, but a deeper disorientation. Maybe it was just instinct. Or maybe it was something my father had said to me years ago when I told him I wanted to be a doctor. We'd been sitting on the back porch of our small house in Houston, and he'd just come home from a 14-hour shift doing construction work. His hands were calloused and scarred, and I remember thinking how I wanted a different life, one where I worked with my mind instead of breaking my back. "Mijo," he'd said in Spanish, "when you become a doctor, remember something. The people nobody sees, the people everyone walks past, they're people too. They have families, they have stories. Don't ever forget to see them." I thought about that as I pushed through the door to Bay 7. Bay 7 was one of the smaller treatment rooms, tucked in a corner away from the main action. The lights inside had a yellowish tint, older fixtures that the hospital kept meaning to replace. I helped the nurses transfer Gerald from the stretcher to the bed, and he didn't resist much. His combativeness had faded into a kind of sluggish compliance. "Gonna start your IV, Gerald?" said Rosa, one of our veteran ER nurses. She had the kind of calm competence that came from 20 years of handling every situation imaginable. "Just a little stick, okay?" Rosa was the kind of nurse every resident hoped to work with. She knew the protocols inside and out, could start an IV on anyone no matter how difficult their veins were, and had an uncanny ability to read patients. More than once, she'd pulled me aside to say, "Something's not right with the patient in Bay 12" before any obvious signs appeared. I'd learned to trust her instincts. Gerald's arm flopped loosely as she tied the tourniquet. His eyes drifted around the room, unfocused, like he was having trouble tracking movement. I pulled up a stool and sat at his bedside with a clipboard, ready to do the basic intake. "Gerald, I'm Dr. Reyes," I said, keeping my voice gentle. "Can you tell me what happened tonight?" His lips moved, but the words came out jumbled. The The third floor. I didn't finish. How much did you have to drink tonight, Gerald? His brow furrowed like he was trying to remember. Drink? No, I don't. I had to clean. Gerald, it's okay. We're not here to judge you. We just need to know so we can help you. How much alcohol did you have? He looked at me with confusion in his eyes. Real confusion. Not the shifty evasiveness of someone hiding their drinking, but genuine bewilderment at the question. I don't drink, he said, the words coming slowly but more clearly than before. Not anymore. I stopped. Long time ago. Rosa glanced at me with a knowing look. Denial was common. She hung the bag of IV fluids, what we called a banana bag because of its yellow color, packed with thiamine and folic acid and other vitamins that chronic alcohol users often needed. I continued the basic exam, listened to his heart, regular rhythm, no murmurs, lungs clear, abdomen soft, non-tender. But when I checked his reflexes, something caught my attention. I tapped the patellar tendon below his right knee with the reflex hammer. Normal response. His leg kicked out in the expected way. Then I moved to the left side. The hammer barely touched the tendon and his leg jerked up forcefully. The response exaggerated. I frowned and did it again. Same result. Then I checked his upper extremities. Right biceps reflex, normal. Left biceps reflex, hyperactive. Rosa, can you hand me the pen light? I checked his pupils. Both reacted to light, but the left pupil seemed just slightly larger than the right. Maybe a millimeter. Could be normal variation, could be nothing, but asymmetry always meant something. I ran through the basic neurological exam, had him squeeze my hands with equal force. His right hand grip was strong. His left hand barely closed around my fingers. Gerald, push against my hands with your feet. I placed my hands against the soles of his feet and asked him to press. Right side, good strength. Left side, noticeably weaker. My pulse quickened. Gerald, can you smile for me? I asked. He tried, and his face moved mostly symmetrically, but there was something off about the left side. A slight droop, barely perceptible. The corner of his mouth didn't quite lift as high as the right. I stood up, my mind racing through differential diagnoses. Unilateral weakness, hyperreflexia on one side, possible facial droop. These were upper motor neuron signs, problems with the brain or spinal cord, not the peripheral nerves or muscles. Stroke was the obvious consideration, but strokes usually came on suddenly, not gradually, and they didn't typically present with confusion that could be mistaken for intoxication. Hemorrhage, tumor, infection. I stepped out of the bay, scanning the ER for Marcus. He was across the floor, helping prep for the trauma patients who were about to arrive. The ambulance sirens were right outside now, the sound cutting through the walls. I walked quickly to where he stood, and he looked up from the trauma bay setup with raised eyebrows. Noah, you should be clearing Bay 7 and getting ready to help here. Marcus, I think something's wrong with the guy in 7. Gerald, the maintenance worker. Wrong how? He's drunk. I know, but his neuro exam is off. Asymmetric reflexes, left-sided weakness, possible facial droop. His pupil, Noah. Marcus's tone shifted into teaching mode, but there was impatience underneath it. You're seeing zebras instead of horses. The guy smells like he bathed in whiskey. Security says he's got a history of drinking on the job, and you're finding soft signs that could easily be explained by intoxication. Alcohol affects coordination, reflexes, everything you're describing. I know, but think about the base rates here. How many drunk people come through this ER every night? 20? 30? How many of them have subdural hematomas or brain tumors? Maybe one every few months. You're letting a low-probability diagnosis distract you from the obvious explanation right in front of you. But the weakness is clearly asymmetric. Alcohol causes all kinds of neurological changes. Cerebellar dysfunction, peripheral neuropathy, even Wernicke's encephalopathy. Not to mention the guy probably hasn't eaten a decent meal in days, which compounds everything. You give him fluids, vitamins, time to sober up, and I guarantee you those findings disappear. Everything Marcus said made logical sense from a Bayesian reasoning standpoint. Prior probability mattered. When you hear hoofbeats, think horses, not zebras. It was one of the first principles they taught us in clinical reasoning. But something still felt wrong. We're about to get slammed with a multi-vehicle accident, Marcus continued. 3 ambulances, at least 1 pediatric patient. I need you focused on that, not on running $1 million workup on someone who needs sleep and AA. What if I'm right? I asked quietly. Marcus paused, his expression softening slightly. Noah, I get it. You're new. You want to be thorough. You don't want to miss anything. But part of being a good emergency physician is learning to manage resources, to triage not just patients but also your own time and the department's capabilities. We can't CT scan everyone who comes in with neurological symptoms and an alternative explanation. We'd bankrupt the hospital and expose hundreds of people to unnecessary radiation. He wasn't wrong. Healthcare economics was real. Over-testing was a problem. Defensive medicine drove up costs without necessarily improving outcomes. I'd still like to order a CT scan, I said. Marcus stopped what he was doing and looked at me fully. His eyes were tired. He'd been on shift for 8 hours already, and we had at least 4 more to go. You're serious? I am. Noah, you know what a head CT costs? You know what the radiation exposure is? You know what our quality metrics look like when we scan everyone who comes in smelling like booze? I understand, but nothing. You're a first-year resident. Part of learning emergency medicine is learning resource stewardship. We can't scan everyone just because you have a feeling. Clinical judgment comes from experience, from seeing patterns, from understanding probabilities. I've seen hundreds of these cases. You've seen maybe a dozen. Trust me on this. The first trauma patient burst through the doors behind us. A teenager on a backboard, paramedics shouting out vitals, visible blood, the organized chaos of a major trauma. Dr. Chen, we need you, one of the nurses called. Marcus pointed at me. Handle the intake and basic labs on the drunk in Bay 7. Nothing more. Then get over here to help. He turned toward the trauma. His attention already shifted completely. I stood there for a moment, watching the trauma team swarm the new patient, feeling the weight of the decision in my hands. I could follow orders, do the basic workup, let Gerald sleep it off, move on to where I was really needed, where lives were obviously dramatically at stake. Or I could trust what I'd seen, trust the subtle asymmetries that my hands had felt, that my eyes had caught, trust my instincts, even though I had so little experience compared to Marcus. In medical school, they taught us about hierarchies, about respecting the chain of command, about learning from those with more experience. The entire structure of residency was built on graduated responsibility. Interns handled the basics, second years got more autonomy, third years like Marcus were nearly independent. But they also taught us about patient advocacy, about being the voice for those who couldn't advocate for themselves, about speaking up when something didn't feel right, even if it meant challenging authority. I thought about Gerald's face, the confusion in his eyes when I'd asked about drinking, the way he'd said, "I don't drink, not anymore." There'd been something in his voice, not defensiveness, but truth, sadness maybe, the weight of a past he'd overcome. And I thought about what would happen if I was right and did nothing. If Gerald did have something serious, a bleed, a tumor, an infection, and we missed it because everyone assumed drunk. I walked back to Bay 7. Gerald was lying still now, eyes closed, the IV dripping steadily into his arm. Rosa was checking his blood pressure. "Rosa," I said quietly, "I need to order a non-contrast head CT." She looked at me with surprise. "Dr. Chen approved that?" I hesitated for just a moment. Then I said, "I'm ordering it." She studied my face for a long moment. Rosa had been nursing longer than I'd been alive. She'd seen residents come and go, had watched some of them make brilliant calls, and others make terrible mistakes. I could see her weighing something in her mind. "You're sure about this?" she asked. "I'm sure something's wrong. Whether it's a CT level wrong, I don't know, but I can't not look." She nodded slowly. "Okay, you're the doctor, but you know you're going to catch hell for this if it comes back negative." "I know." I sat down at the computer terminal in the bay and pulled up the ordering system. My hands hovered over the keyboard. I thought about Marcus's words, about resource stewardship, about learning clinical judgment. I thought about the statistics, the probabilities, the fact that I was only 4 months into residency and he had years more experience than me. Then I thought about that reflex hammer kicking back just a little too hard on the left side, that pupil, just slightly too large, that grip, noticeably weaker. And I thought about my father's words, "See them, don't walk past." I typed in the order for a CT scan of the head without contrast. Indication: altered mental status with focal neurological findings. Rule out intracranial pathology. My cursor hovered over the submit button. Once I clicked it, there was no taking it back. Marcus would see the order. He'd be angry. I might be wrong, and if I was wrong, I'd look like an over-testing, resource-wasting intern who didn't know how to prioritize. But if I was right, I clicked submit. Then I waited. The next 20 minutes were a study in controlled chaos. The trauma bay erupted with activity as the accident victims came in. A 17-year-old boy with a possible spinal injury, a middle-aged woman with a compound fracture of her femur, and the driver of the other vehicle with chest trauma. Dr. Okoye orchestrated the response like a conductor, calling out orders, directing the flow of personnel and resources. The teenage boy was screaming in pain, his neck immobilized in a cervical collar, his parents somewhere behind in another ambulance. The woman with the fractured femur had bone protruding through her skin, blood soaking through the sheets. The other driver was unconscious, possible flail chest, every breath a struggle. I should have been there. I should have been helping with the intubation, starting lines, running blood work. Instead, I was in Bay 7, waiting for transport to come take Gerald to radiology. He'd grown quieter. His eyes would flutter open occasionally, unfocused, then drift closed again. His breathing was steady, vitals stable, blood pressure a little elevated at 158/92, but not alarmingly so. Heart rate in the 80s. Oxygen saturation good at 97% on room air. Everything looked fine, except it didn't. Not to me. I checked his neurological status again. The left-sided weakness was still there. If anything, it seemed slightly more pronounced than before. His left hand, when I placed my pen in it and asked him to squeeze, barely closed around it. I did a pronator drift test, had him hold his arms out in front of him, palms up with his eyes closed. Within seconds, his left arm began to drift downward, pronating inward. That was a definitive upper motor neuron sign. Not subtle, not ambiguous. "Gerald, can you hear me?" I said, louder this time. His eyes opened halfway. I'm going to get some pictures of your head, okay? Just to make sure everything's all right." He didn't respond, just drifted again into that semi-conscious state. I watched his chest rise and fall, monitoring for any changes in his breathing pattern. Increased intracranial pressure could affect respiratory drive. So far, his breathing remained regular. Rosa came back in with the lab results I'd ordered. Basic metabolic panel, complete blood count, liver function tests, and a blood alcohol level. I pulled up the results on the screen and felt my stomach drop. Blood alcohol, 0.02%, 0.02. That was barely anything. The legal limit for driving was 0.08%. A glass of wine with dinner might get you to 0.02%. This level wouldn't cause significant impairment in anyone, let alone the profound confusion and weakness Gerald was showing. "Rosa, look at this." She leaned over my shoulder and saw the number. Her expression changed immediately. That's essentially sober." "I know." "Then what's wrong with him?" "That's what I'm trying to find out." She looked at Gerald with new eyes now, seeing him not as a drunk sleeping it off, but as a diagnostic mystery, a patient in trouble. "His pressure's climbing," she noted, pointing to the monitor. 162/95 now. Rising blood pressure with the deteriorating neurological exam. That could be a Cushing's response, the body's reaction to increased pressure inside the skull, trying to maintain blood flow to the brain. The transport team arrived with a wheelchair, ready to take Gerald to radiology. I stopped them. "We need a stretcher, not a wheelchair, and I want someone monitoring him continuously. If his mental status changes at all, if he vomits, if his breathing changes, I want to know immediately." The transport tech, a young guy named Carlos, looked surprised. "I thought this was just a drunk." "It's not. This is a possible neuro-emergency." His demeanor changed instantly. Within minutes, they had Gerald on a stretcher, monitoring equipment attached, ready for transport. As they wheeled him away, I stood in the empty bay, staring at the lab results on the screen. 0.02%. Everyone had been wrong. The paramedics, the security guards at his building, Marcus. Everyone had smelled alcohol and stopped thinking, stopped considering alternatives, including, almost, me. I walked back out into the main ER. The trauma situation was stabilizing. The patients were being worked up, some headed for surgery, others for ICU admission. The teenage boy was being prepped for an emergency MRI to rule out spinal cord injury. The woman with the fractured femur was going to orthopedic surgery. The other driver was being intubated for airway protection. Marcus was at the central station, rapidly typing notes, his face set in concentration. I could see Dr. Okoye in the background moving between patients, her experienced hands working quickly, her voice calm as she directed the team. I approached Marcus carefully. "Marcus." He didn't look up. "I told you I needed you for the traumas. Gerald's blood alcohol is 0.02%. That got his attention. His fingers stopped typing. He turned to look at me, his expression shifting from irritation to confusion. "What?" 0.02. He's essentially sober. But his neuro exam is worse. Left-sided weakness is more pronounced. He's increasingly lethargic. His blood pressure is climbing. Cushing's response. Marcus stared at me for a long moment. I could see the wheels turning in his mind, reassessing, recalculating probabilities. His face went through several expressions: surprise, concern, then something that looked like defensiveness mixed with the beginning of realization. The lab could be wrong. Send it again. I'm sending him for the CT now. He's already on the way to radiology. Noah, something is really wrong with him, Marcus. This isn't intoxication. It never was. For a long moment, we stared at each other. Around us, the ER continued its relentless pace, monitors beeping, nurses calling out, the low hum of urgent conversations. I could hear a child crying in the pediatric section, someone retching in one of the bays, the pneumatic whoosh of the automatic doors as another ambulance arrived. Finally, Marcus nodded once, curtly. Fine, get the scan. But Noah, if it's negative, you and I are having a serious conversation about clinical judgment and chain of command. You don't just override your supervising resident's orders because you have a gut feeling. Understood, but we both knew something had shifted. The certainty that had been in his voice earlier was gone, replaced by doubt. He was reconsidering, running back through the presentation in his mind, wondering what he'd missed. I didn't respond further. I just walked toward radiology. The corridor leading to the imaging department was quieter than the ER. The fluorescent lights humming overhead, the smell of antiseptic stronger here. My footsteps echoed on the linoleum floor. I passed a family in the waiting room, huddled together, waiting for news about their loved one. Past a patient in a wheelchair, elderly, being taken somewhere by an aide. The CT scanner sat behind thick walls, its entrance marked with radiation warning signs. Through the observation window, I could see Gerald being positioned on the table by the tech. His body was limp, requiring full support from 2 technicians to center him properly on the scanning bed. I'd never wanted to be wrong more in my life. I hoped the scan would come back completely normal, that I'd been seeing patterns where there were none, that I'd overreacted based on minimal findings, that I'd look foolish and over-testing, and Marcus would have every right to lecture me about resource stewardship and clinical judgment, because if I was right, if there was something serious showing up on that scan, it meant Gerald had been deteriorating while everyone around him assumed he was just drunk. It meant he'd been written off, dismissed, left to sleep it off, while potentially dying. It meant the system had failed him at multiple points. Security who called him drunk, paramedics who didn't look deeper, triage nurses who accepted the obvious explanation, and it meant I'd almost failed him too. I'd almost listened to Marcus and moved on. The technician's voice came through the intercom. Dr. Reyes, we're about to start the scan. Should be about 10 minutes. I nodded, even though she couldn't see me. I found a chair in the observation area and sat down, watching through the window as Gerald disappeared into the donut-shaped machine. 10 minutes felt like an hour. I thought about my parents, about the sacrifices they'd made to get me here. My father had worked construction for 20 years, his hands scarred and weathered from hard labor in the Houston heat. My mother cleaned houses, scrubbing other people's toilets and floors so their children could have a better life. They'd both worked multiple jobs to help pay for my education, even though I'd told them I had scholarships and loans covered. They wanted to contribute. They wanted to be part of my success. They'd come to the United States from El Salvador in the 1990s, fleeing violence and poverty, crossing borders with nothing but hope and determination. They'd built a life from nothing, learned a new language, worked jobs that broke their bodies but kept their family fed and housed. They wanted me to be a doctor because it meant I'd never have to break my back for minimum wage, never have to be invisible in the service industry, never have to wonder if an illness would bankrupt the family. But they also raised me to see people, really see them, not as problems to solve or statistics to manage, but as human beings with stories, with families, with worth. My father told me once about a time he'd been injured on a construction site. A nail gun had misfired and gone through his hand. He'd gone to the ER, and the doctor there had barely looked at him, treated him like an inconvenience, like another uninsured laborer taking up space. My father said the pain of being invisible hurt worse than the nail through his hand. When you're a doctor, mijo, he'd said, his eyes serious, don't ever make someone feel invisible. Don't ever look at them and not see a human being. Gerald had a name patch on his uniform. That meant he'd been working at that building long enough to earn a permanent position, long enough to warrant a name tag. Someone knew him. Someone expected him to show up for his shift. Maybe he had a family. Maybe he'd been a good employee for years before whatever this was started affecting him. And everyone, including Marcus, including the paramedics, including building security, had seen him and thought, drunk, problem employee. Not our concern beyond making sure he doesn't hurt himself. The scanner hummed and whirred, a rhythmic sound that filled the observation room. I watched the technician monitoring the images as they appeared on her screen, but I couldn't see details from where I sat. Then her posture changed. She leaned forward, closer to the monitor. Her hand reached for the phone on the desk beside her. Even from where I sat, I could see the tension in her shoulders, the sudden alertness. My heart started pounding. The intercom crackled. "Dr. Reyes, I'm calling the attending radiologist. You need to see this. Now." I was out of the chair and pushing through the door before she finished the sentence. The technician, a woman named Diane who I'd seen around but never really talked to, had the images up on the large monitor above her workstation. She pointed without saying anything, her face grave. There, in stark black and white, was the inside of Gerald's skull. And taking up a significant portion of the right side of his brain was a mass. A large, irregular mass that was pushing everything else aside. The white crescent-shaped collection of blood was unmistakable, pressed against the gray brain tissue beneath it. Around it, I could see the telltale signs of edema, swelling, and what looked like a small amount of additional bleeding at the margins. "Is that," I started. "A subdural hematoma," came a voice behind me. Dr. Okoye had arrived, alerted by Diane's call. She stepped up to the monitor, her experienced eyes scanning the images quickly. "Significant one, with mass effect. You can see the midline shift here." She traced a line with her finger, showing how the normal central structures of the brain, the falx cerebri, the third ventricle, had been pushed to the left by the pressure of the bleeding mass on the right. The shift was dramatic, at least 7 or 8 millimeters. That was serious. That was life-threatening. My legs felt weak. How long has that been there? Days, probably, maybe a week or more. Subdurals can be slow bleeds, especially in older adults or people with clotting issues or chronic alcohol use. The brain atrophies slightly, leaving more space for blood to accumulate before symptoms appear. They deteriorate gradually, then rapidly once they reach a critical size. She turned to look at me. "Good catch, Dr. Reyes. How'd you decide to scan him? Asymmetric reflexes, subtle weakness on the left, facial droop, and his BAC came back at 0.02%. She nodded slowly, still looking at the images, her finger tracing the outline of the hematoma. "Everyone assumed drunk?" "Yes." "Including Dr. Chen?" I hesitated, not wanting to throw Marcus under the bus, but knowing honesty mattered here. He thought I was overreacting, that I was seeing zebras instead of horses. Dr. Okoye made a non-committal sound, but I could see something in her expression. Not judgment, exactly, but a kind of weary recognition. She'd probably seen this pattern before. The easy assumption, the missed diagnosis, the near tragedy averted only by someone willing to look twice. She picked up the phone and started dialing. "I'm calling neurosurgery. This man needs an OR immediately. That hematoma needs to be evacuated or he's going to herniate." She looked at me while she waited for the call to connect, her dark eyes serious. "What's his name?" "Gerald." "Gerald." I realized I didn't know his last name. I'd been so focused on the medical mystery that I hadn't asked basic information about him as a person, hadn't taken a proper history, hadn't learned his story, find out his full name, find out if he has family. Someone needs to consent for surgery, and someone needs to be notified that he's here and in serious trouble. The call connected, and she started speaking rapidly to whoever was on the other end. Using medical shorthand, I only partially followed. "Neurosurg, this is Okoye in the ED. I've got a 61-year-old male with a large right-sided subdural hematoma with significant midline shift. Yes, acute on chronic by the appearance. GCS declining, currently around 10. Yes, he needs to be in your OR in the next 30 minutes or we're looking at herniation." I ran back to the ER, my heart pounding, adrenaline coursing through my system. Marcus was still at the central station, and I didn't even slow down as I passed him. "It's a subdural hematoma. Large. Significant midline shift. Needs emergency surgery." To his credit, Marcus immediately followed me, his face draining of color. "Are you serious? Dr. Okoye is calling neurosurg right now. It's bad, Marcus, really bad." "Jesus Christ." He ran a hand through his hair. "I was completely wrong. He stopped, seeming unable to finish the sentence. We reached Bay 7 where Gerald's belongings had been stored in a plastic bag. His wallet, keys, a worn cell phone with a cracked screen, a battered lunchbox. I pulled out his wallet and found his ID card, slightly yellowed with age. Gerald Morrison, age 61. Address in a part of town I knew was mostly older apartment buildings and rental units, a working-class neighborhood not far from the hospital. His wallet also contained several cards, a library card from the public library downtown, well worn, a grocery store rewards card, a membership card for a gym that had closed years ago, based on the faded logo, and tucked in one of the slots, creased and faded from being carried for years, was a photograph. It showed Gerald, maybe 20 years younger, with significantly less gray in his hair. He was smiling broadly, his arm around a woman with kind eyes and curly brown hair. 2 children stood in front of them, a boy maybe 10 years old and a girl around 7 or 8, both grinning at the camera. They were standing in front of what looked like a park or playground, trees in the background. A bright summer day captured forever in that faded photo. I stared at that photo and felt something crack open in my chest. This wasn't just a case. This wasn't just an interesting diagnostic puzzle or a learning opportunity or a near miss to discuss an M&M conference. This was someone's father, someone's husband maybe, someone who existed in other people's lives as more than a maintenance worker in a stained uniform, someone who'd once been young and happy, standing in a park with his family on a summer day, someone who'd almost died tonight because everyone saw what they expected to see instead of what was really there. Marcus was looking over my shoulder at the wallet contents. His face had gone pale, and I could see his hands shaking slightly. "I was wrong," he said quietly, his voice hollow. "I was completely wrong about everything. We need to find his family," I said, my voice tight with emotion I was trying to control. "The phone? Can we unlock it?" I pressed the power button on Gerald's cell phone. It lit up but required a passcode, a 4-digit PIN. The background image, though, showed the same woman from the photo, older now. Her hair grayer, but her smile just as warm. She was standing in what looked like a garden, holding a basket of tomatoes. "Check for an ice contact," Marcus suggested, his voice steadier now, focusing on the practical steps. Ice, in case of emergency, some people programmed that into their phones, making it accessible even without unlocking the device. But Gerald's phone was an older model. No emergency contact information accessible from the lock screen. Rosa appeared in the doorway, slightly out of breath. "Neurosurg is on their way down. Dr. Khalil himself. They want him in the OR in 20 minutes maximum. We need consent." Dr. Okoye came in behind her, her expression serious but controlled. "Without family, we can invoke emergency consent if the patient can't consent themselves and surgery is life-saving. We document that we made a good faith effort to contact next of kin, and we proceed. But let's make that good faith effort count." "His workplace," I said suddenly. "Preston Building. Security there might have emergency contact information on file. Employee records." Marcus was already on his phone, looking up the number. His fingers moved quickly across the screen, and within seconds, he had the main security desk on the line. "This is Dr. Marcus Chen from St. Halstead Hospital Emergency Department. We have one of your employees here, Gerald Morrison, maintenance staff. He's critically ill, and we need to contact his family immediately. Do you have emergency contact information?" I watched Marcus's face as he listened to the response, saw his expression tighten, saw something like anger flash in his eyes. "Yes, I'm aware of the report that he was intoxicated. That report was incorrect. Mr. Morrison has a life-threatening medical emergency requiring immediate brain surgery. Now I need that contact information." His voice had taken on an edge I'd never heard before, sharp, commanding, brooking no argument. There was a pause. Then Marcus grabbed a pen and started writing on a paper towel. "Yes, Helen Morrison. Phone number?" He scribbled quickly. "And you're absolutely certain this is current? Good. Thank you." He hung up and immediately dialed the number he'd written down. I held my breath as the phone rang once, twice, 3 times. Then a woman's voice answered, tentative. "Hello? Mrs. Morrison? Mrs. Helen Morrison? Yes? Who is this?" "Ma'am, my name is Dr. Marcus Chen. I'm calling from St. Halstead Hospital. Your husband Gerald is here in our emergency department. He has a serious medical condition that requires immediate surgery." Even standing a few feet away, I could hear her sharp intake of breath, the immediate terror in her voice. "What? Gerald, but he's at work. He's just at work. What happened? What's wrong?" Marcus's voice gentled. "Mrs. Morrison, can you come to the hospital right away?" We're going to take very good care of your husband, but we need you here to sign consent forms for surgery, and he'll want you here when he wakes up." "Surgery? What kind of surgery? Is he going to be okay?" Her voice was rising, panic setting in. "Ma'am, the neurosurgeon will explain everything when you arrive. Are you able to drive, or do you need us to send someone?" "I can drive, I'm coming right now." 20 minutes. "Tell him I'm coming. Tell Gerald I'm coming." "We will, Mrs. Morrison. Drive safely." He hung up and looked at me, his expression raw. She didn't even know he was here. Nobody called her. Security just assumed he'd sleep it off and written him up for drinking on the job. The full weight of what had almost happened settled over the room. If I hadn't insisted on the scan, if we'd just put Gerald in Bay 7 with a banana bag and let him sleep it off like Marcus had originally ordered, if we'd followed the obvious conclusion that everyone else had reached, Gerald Morrison would have died. Maybe not immediately, maybe not even in the ER, but somewhere in the night, as the pressure in his skull continued to build, as the hematoma continued to grow, his brain would have herniated, pushed down through the opening at the base of his skull, crushing the brainstem, stopping his breathing, ending his life, and his wife would have gotten a call in the morning, not to come to the hospital, but to identify his body. Rosa interrupted my dark thoughts. Neurosurg is here. Dr. Rashid Khalil swept into the ER with his team, a senior neurosurgical resident and an OR nurse who immediately began preparations. Dr. Khalil was in his 50s, with silver gray hair, and the kind of calm intensity that comes from years of operating on the most delicate organ in the human body. He went straight to the computer terminal and pulled up Gerald's CT images. His eyes moved rapidly across the screen, taking in every detail in seconds: the size of the hematoma, the degree of midline shift, the signs of increased intracranial pressure, the small areas of new bleeding at the margins. "Large, acute on chronic subdural," he said, his voice matter-of-fact. "You can see the different densities. The older, more liquefied blood mixed with fresh bleeding. Significant mass effect. GCS? Was 10 when we brought him back from CT, Dr. Okoye reported, declining gradually. Any anticoagulation? Blood thinners?" I suddenly realized I hadn't asked, hadn't taken a medication history. I'd been so focused on the neurological exam that I'd skipped basic history taking. "Unknown," I admitted. "His wife is on her way. She should be here in about 15 minutes. Dr. Khalil nodded. "We don't have 15 minutes. We're going to OR now. I'll get consent when she arrives, but we're invoking emergency procedures. This man will herniate within the hour if we wait." He looked at his resident. "Call the OR. Tell them we're coming up. Craniotomy for subdural evacuation. I want the neuro ICU on standby for post-op." The team moved with practiced efficiency. Gerald was being prepped for transport. New IV lines started, monitoring equipment attached, medications drawn up. The whole ER seemed to shift around this one patient, this one critical situation. Dr. Khalil turned to me. "Who caught this?" "Dr." Okoye pointed at me. "Dr. Reyes, first-year internal medicine resident, rotating through the ED." Dr. Khalil looked at me with sharp, assessing eyes. "What made you scan him?" I explained quickly. The asymmetric reflexes, the focal weakness, the pupil findings, the blood alcohol level that didn't match the presentation. He nodded slowly. "Good clinical skills, and more importantly, good instincts. Everyone else saw drunk. You saw sick. That's the difference that matters." He paused. "You probably saved this man's life tonight. I hope you know that." Then they were wheeling Gerald away toward the elevators that would take him to the surgical floor. I watched him disappear around the corner. This man I'd spent maybe 45 minutes with, this person whose life had somehow become entangled with mine in the most profound way. Dr. Okoye put a hand on my shoulder. "Good work, Noah. Really excellent work." Marcus stood nearby, silent, watching the empty space where Gerald had been. Then Helen Morrison burst through the ER doors. She was a small woman, maybe late 50s, wearing a cardigan that looked hand-knitted jeans and house slippers like she'd run out the door without thinking. Her hair was uncombed, her face white with terror, her hands shaking visibly. "Where is he?" she demanded, looking around wildly. "Where's Gerald? Where's my husband?" I stepped forward. "Mrs. Morrison, I'm Dr. Reyes. Your husband is being taken to surgery right now. The neurosurgeon?" "Surgery? What kind of surgery? What's wrong with him?" She grabbed my arm, her grip surprisingly strong. "Please tell me what's happening. They called me from his work and said he was drunk, that he'd been found passed out. But Gerald doesn't drink. He hasn't had a drink in 15 years, not since he went to AA. He wouldn't. Her voice broke on the last word, and I could see her fighting to maintain control, to not fall apart in this public space surrounded by strangers. Dr. Okoye stepped in, her voice gentle but authoritative. "Mrs. Morrison, I'm Dr. Okoye, the attending physician here. Your husband has a serious injury to his brain, a collection of blood between his skull and his brain that's causing pressure. It's called a subdural hematoma. It has nothing to do with alcohol. This is a medical emergency, and we caught it in time to operate, which gives him a very good chance. But how did this happen? He didn't fall. He didn't hit his head. At least, not that I know of." Helen looked between us, desperate for understanding. "Sometimes these bleeds happen from very minor trauma that seemed insignificant at the time," Dr. Okoye explained, her voice patient, walking Helen through this like she'd done for hundreds of families before. "A small bump, maybe hitting his head on a cabinet, something that didn't even seem worth mentioning. Or sometimes they can happen spontaneously, especially in people who take certain medications or have certain medical conditions. Has Gerald complained of headaches lately? Any confusion? Any changes in his behavior or personality?" Helen's face crumpled as understanding dawned. He's been having terrible headaches for the past week. Said it felt like pressure in his head, like his skull was too tight. He took aspirin, but it didn't really help. And he seemed confused a few times, like he'd forget what he was saying mid-sentence, or he'd put things in strange places. Found his car keys in the refrigerator 2 days ago. I thought maybe it was stress. Tears started flowing down her face. He's been working extra shifts because we're trying to save up for our daughter's wedding. She's getting married in 2 months and we want to help pay for it, to give her a beautiful day. Gerald's been working so hard, pushing himself, taking every extra shift they offered. The aspirin explained the bleeding. It was a blood thinner, and if he had a small initial bleed from minor trauma, the aspirin would have prevented it from clotting, allowing it to grow slowly over days. "Mrs. Morrison," Dr. Okoye continued, "your husband is in the best possible hands. Dr. Khalil is one of the finest neurosurgeons in the state. He's going to open your husband's skull, carefully remove the blood collection, and relieve the pressure on his brain. It's a delicate operation, but Dr. Khalil has done hundreds of these procedures." "How long will it take?" Helen asked, wiping her eyes with shaking hands. "Several hours. At least 4, possibly 6 or more, depending on what they find when they open the skull. There's a surgical waiting room on the 3rd floor. Someone will come update you periodically during the operation." Helen looked around the ER as if seeing it for the first time. The bright lights, the urgent activity, the other patients in various states of distress. Then she looked at me, really looked at me, and I saw recognition dawn in her eyes. "You're the one who found it, aren't you?" she said. "The nurse who called me, she said a young doctor insisted on getting a scan even though everyone thought—" She stopped, unable to finish the sentence. "I just did what needed to be done," I said, uncomfortable with the intensity of her gaze. "No." Her voice was firm despite the tears. "No, you did more than that. You looked at my husband when everyone else looked past him. You saw him as a person who mattered, not just—" She took a shaking breath. "Not just a drunk janitor sleeping it off." The words hung in the air. That's exactly what he'd been to everyone else. A drunk janitor. A problem to be managed, not a person to be saved. "Gerald is the best man I know," Helen continued, her voice strengthening as she talked about him. "He made mistakes when he was younger, back when our kids were small. He drank too much, lost jobs because of it, put us through hell. But he got sober 15 years ago, went to AA, did the work, rebuilt his life from nothing, got his job at Preston Building and has never missed a day of work in 12 years. Never. He's proud of that. He's proud of being reliable, of being the man his family can count on." She looked at me with fierce intensity. "And they were going to fire him. The security guard told me when I called looking for him. They'd already written up the paperwork to terminate him. Thought he'd fallen off the wagon after all these years." I felt sick. Gerald had worked for 12 years, building trust and reliability. And in one night of medical crisis that presented as intoxication, he'd been written off completely. "Mrs. Morrison," Marcus said, stepping forward, "I owe you an apology. I'm Dr. Chen, Dr. Reyes' supervisor. When your husband came in tonight, I made the same assumption everyone else did. Dr. Reyes was the only one who looked deeper, who insisted on investigating when I told him not to. If it weren't for his persistence, for his refusal to accept the obvious explanation." He didn't finish the sentence. He didn't have to. Helen looked at Marcus, then back at me, understanding passing between all of us. How close this had been. How easily Gerald could have been lost. A young woman burst through the ER doors then, her face streaked with tears, wearing scrubs that identified her as working at a nearby dental office. She looked so much like the little girl in the photo from Gerald's wallet that I recognized her immediately. "Mom!" she called out, and Helen turned, opening her arms. They embraced, both crying, and I heard Helen explaining in rapid, broken sentences what had happened. The daughter, Gerald's daughter, looked at us with wide, terrified eyes. "Is my dad going to die?" she asked, her voice small despite being a grown woman. "The surgery gives him an excellent chance," Dr. Okoye said, her voice carrying the weight of experience and honesty. "Brain surgery is always serious, and there are risks. But Dr. Khalil is very skilled, and we caught this in time. The next few hours will tell us a lot." Rosa appeared with paperwork, consent forms that Helen needed to sign for the surgery that was already underway. As Helen signed with shaking hands, her daughter standing close beside her, I thought about all the near misses that happen in medicine. All the times we almost get it wrong. All the patients who fall through the cracks because they don't fit the expected pattern, because they're dismissed or overlooked or assumed to be something they're not. How many Gerald Morrisons are out there who weren't as lucky, who didn't have someone willing to look twice, after Helen and her daughter were escorted to the surgical waiting area, after the ER returned to its normal controlled chaos, after new patients arrived and the cycle continued? I found myself standing in the supply room, hands braced against a metal shelf, trying to process what had just happened. Marcus found me there. "Noah," he said quietly. I turned to face him. "I've been practicing emergency medicine for 3 years," he said. "I've seen thousands of patients, I've made good calls and I've made mistakes, but tonight," he stopped, searching for words. "Tonight I almost made a mistake that would have killed someone. Because I was so confident in my pattern recognition, so certain that I knew what I was seeing, that I stopped actually looking. I stopped being curious. I stopped considering alternatives. It was a reasonable assumption," I started. "Stop! Don't let me off the hook." His voice was sharp. "I need to own this. I need to remember this feeling, this moment, because this is how doctors kill people. Not through incompetence or lack of knowledge, but through certainty, through assumptions, through stopping our diagnostic reasoning too soon because we think we know the answer." He ran both hands through his hair, a gesture of frustration and emotional exhaustion. "You know what the worst part is? I've given lectures on cognitive biases. I've presented at conferences on avoiding premature closure. I know this stuff intellectually, but when it mattered, when there was a real patient in front of me, I fell into every trap I'd warned others about. So we learn from it," I said. "We both learn from it. You're right." He took a deep breath, composing himself. "And I'm going to make sure everyone else learns from it too. This case is going into our M&M conference. We're going to dissect every decision point, every bias, every assumption, and I'm going to stand up there and admit my role in almost missing this diagnosis." M&M, Morbidity and Mortality Conference, was where doctors reviewed cases that had complications or unexpected outcomes. It was meant to be a learning environment, but it required humility and honesty to present your mistakes in front of your colleagues. "That takes courage," I said. "It takes responsibility, something I should have taken more seriously tonight." He looked at me directly. "Thank you, Noah. Thank you for not listening to me. Thank you for trusting your instincts over my experience. You saved a man's life tonight by being willing to question authority." The surgery took 6 hours and 23 minutes. I stayed at the hospital even though my shift ended at 7 a.m. I couldn't leave without knowing how Gerald's story ended. Every hour or so, I checked the surgical board, watching the status next to his name. In progress, proceeding, closing. Helen and her daughter remained in the surgical waiting room the entire time, joined eventually by other family members. The son from the photo, now a man in his 30s who looked like a younger version of Gerald, and various relatives who came to sit vigil. I checked on them periodically, bringing coffee from the cafeteria, sitting quietly when they needed someone there who understood the medical side of what was happening. It wasn't technically my job. Gerald wasn't my patient anymore once he went to surgery, but I couldn't walk away. Around 1 p.m., as I was checking on the family for what felt like the 100th time, Helen asked me to sit with her. Her daughter had gone to move their car and make some phone calls, and the waiting room had momentarily emptied of other family members who'd gone to grab lunch. "Dr. Reyes," she said, her voice hoarse from hours of crying and stress. "Can I ask you something?" "Of course." "Why did you keep looking? When everyone else had decided what was wrong with Gerald, why did you keep questioning?" I thought about that question, thought about the reflex hammer in my hand, and the asymmetry I'd felt, thought about the way something had just seemed wrong beyond simple intoxication. My father is a construction worker, I said finally. He's worked hard labor his whole life, came to this country with nothing, built a life through sheer determination. And once, when he was injured on a job site, he went to an emergency room and the doctor there barely looked at him, treated him like he was wasting everyone's time, like he was just another uninsured laborer who didn't really matter. I paused, remembering my father telling me that story, the hurt in his eyes that hadn't faded even years later. My father told me that being invisible hurts worse than any physical pain, and he made me promise that if I became a doctor, I would never make anyone feel invisible, that I would see every person who came through those doors as someone's father, someone's child, someone who matters. I looked at Helen. Gerald matters. He has a family who loves him, a life he's built, a daughter getting married in 2 months. He deserves to be there for that. Everyone deserves to be seen as more than their worst moment, or what people assume is their worst moment. Helen's eyes filled with fresh tears. She reached out and took my hand, squeezing it tightly. Thank you for seeing my husband. Thank you for seeing Gerald. When Dr. Khalil finally emerged from surgery around 2:30 p.m., still in his scrubs, his surgical cap pushed back, his face lined with fatigue but showing satisfaction, I was standing near the waiting room entrance. He saw me first. Dr. Reyes, he acknowledged with a nod. Then he turned to the family gathered in the waiting room, his demeanor shifting to something more formal, more carefully controlled. Mrs. Morrison? Helen stood up, her daughter immediately beside her, supporting her. Yes. How is he? How's Gerald? The surgery went very well, Dr. Khalil said, and I saw Helen's knees buckle slightly with relief. We were able to evacuate the hematoma completely, removed about 120 milliliters of blood, which is substantial. The brain tissue underneath looks healthy, which is excellent news. There was some older blood mixed with fresh bleeding, which confirms this has been developing over several days, probably from minor trauma combined with the aspirin use. Will he be okay? Helen asked, her voice barely above a whisper. If there are no post-operative complications, infection, rebleeding, seizures, I expect him to make a full recovery. The brain is remarkably resilient when pressure is relieved before permanent damage occurs. He'll be in the neuro ICU for at least 48 hours for close monitoring, then likely move to a regular floor. Physical therapy will be needed to address any residual weakness, and there will be follow-up scans to ensure no reaccumulation of blood. But Mrs. Morrison, your husband should walk your daughter down that aisle in 2 months. Helen collapsed into her daughter's arms, sobbing with relief. The son stood up and shook Dr. Khalil's hand, thanking him repeatedly. Other family members were hugging each other, crying, releasing the tension of 6 hours spent waiting for news that could have gone either way. Dr. Khalil spent another 10 minutes explaining the details of the surgery, the ICU protocols, what to expect in recovery. Then he returned to the OR area to write his operative notes and check on his other patients. Before he left, he pulled me aside. You did good work tonight, Dr. Reyes. The hardest part of medicine isn't learning the technical skills or memorizing the facts. It's maintaining the curiosity and humility to question your own conclusions. Don't lose that as you get more experienced. After he left, Helen approached me one more time. Her daughter was with her, and the son came over too, this family united around the father who'd almost been lost. What's your full name? Helen asked. I want to remember it. We want to remember it. Noah. Noah Reyes. Noah Reyes, she repeated, like she was committing it to memory. We're going to remember that name, forever. You gave us back our husband, our father. You gave our family a future we almost lost. Her daughter hugged me, this stranger who'd been through their family's worst crisis with them. Thank you, she whispered. Thank you for not giving up on my dad. I walked out of the hospital into the afternoon sunlight. It was just past 3 p.m. The city was alive with activity. Traffic filling the streets, people going about their days, the world continuing its relentless forward motion. I was exhausted, bone-tired in a way that went beyond just physical fatigue. I'd been awake for nearly 30 hours straight. Every part of my body ached. My eyes burned from staring at computer screens and bright lights. But I also felt something else, something I hadn't felt clearly in the chaotic, overwhelming months of residency so far. I felt like I'd done exactly what I was meant to do, not perfectly, not without doubt or fear, not without making mistakes along the way. But when it mattered most, I'd trusted my instincts. I'd advocated for a patient when everyone else, including my supervising resident, thought I was wrong. I'd been willing to look foolish, to face criticism, to potentially damage my reputation, because a human life was worth it. My phone buzzed with a text from Marcus. "Coffee tomorrow? When you wake up? We should talk." I texted back. "Yeah, thanks for today." His response came immediately. "No, thank you. You taught me something important." I went home to the small apartment I shared with 2 other residents, collapsed on my bed fully clothed, and slept for 14 hours straight. 6 weeks later, I was in the hospital cafeteria grabbing a quick lunch between patients when my phone buzzed with an email. The subject line read, "You're invited." I opened it to find a personal message from Helen Morrison inviting me to their daughter's wedding. "You're part of our family's story now," she wrote. "You gave us this day. It wouldn't be right to celebrate without you knowing how much joy you made possible." I was on call that weekend and couldn't attend, but I sent a card with congratulations and a small contribution toward the newlyweds' honeymoon fund. Helen sent me photos afterward. Gerald in a perfectly fitted tuxedo, his surgical scar barely visible beneath his hair, beaming as he walked his daughter down the aisle. The whole family together, healthy and happy and whole. Multiple generations celebrating together. A future that had almost been stolen. One photo in particular stayed with me. Gerald and Helen dancing together at the reception, his arms around his wife, both of them crying tears of joy. On the back, Helen had written, "Every dance, every laugh, every moment because of you." Gerald's recovery had been remarkable. He spent 3 days in the neuro ICU, then 5 more days on the neurology floor. The left-sided weakness that had been so prominent before surgery resolved completely within a week. His mental status returned to perfect baseline. By the time he was discharged, he was walking independently, talking normally, remembering everything. The neurosurgery team presented his case at their own departmental conference, using it to discuss subdural hematomas with atypical presentations. Dr. Khalil told me later that he used Gerald's case in teaching sessions with residents, emphasizing the importance of thorough neurological exams, even in patients with apparent alternative explanations for their symptoms. At St. Halstead's monthly M&M conference 2 weeks after Gerald's surgery, Dr. Okoye and Marcus co-presented the case. The conference room was packed that day. Attendings, residents, medical students, nursing leadership, even some administrative staff attended. Marcus stood at the front of the room and did something I'd never seen a resident do. He opened with an apology. "This case represents a near miss that would have resulted in a patient death if not for the persistence of a first-year resident who had better clinical judgment than his supervising resident," he said, his voice clear and steady. "I'm that supervising resident, and I'm here to tell you about every mistake I made, every bias I fell victim to, and every lesson I learned." He walked the room through Gerald's presentation, showing the CT images, displaying the lab results. He explained his initial assessment and his reasoning for dismissing my concerns. He talked about anchoring bias, fixating on the first diagnosis that came to mind. He discussed premature closure, stopping the diagnostic process too soon. He addressed availability bias, thinking the diagnosis was common because he'd seen it frequently. But most importantly, he talked about systemic biases. Gerald Morrison came to us as a maintenance worker, smelling of what we assumed was alcohol, with a history reported by security of drinking problems, Marcus said. And every person who encountered him, paramedics, security guards, nurses, doctors, saw those surface details and stopped looking deeper. We made assumptions based on his occupation, his appearance, and secondhand reports about his character. He clicked to a slide that showed a simple question. Would we have made the same assumptions about a professor, a lawyer, a doctor? The room was silent. The research tells us we wouldn't, Marcus continued. Studies show that patients from lower socioeconomic backgrounds, patients who are homeless, patients with histories of substance use, they receive less thorough workups, less aggressive treatment, and have worse outcomes even when presenting with identical symptoms as more privileged patients. We like to think we treat everyone equally, but the data proves we don't. He then walked through the correct diagnostic reasoning, showing how the subtle neurological findings should have triggered immediate concern, how the blood alcohol level should have completely changed our assessment, how the combination of factors pointed clearly to an intracranial process if we'd been willing to see it. Dr. Reyes saved this man's life by doing 3 things, Marcus concluded. First, he performed a thorough physical exam instead of relying on secondhand reports. Second, he followed up on subtle findings that didn't fit the working diagnosis. Third, and most importantly, he refused to accept my authority over his clinical judgment when he believed a patient was in danger. He looked directly at me in the audience. That took courage, It took confidence, and it took a commitment to patient advocacy that superseded hierarchy and convenience. Those are the qualities that make exceptional physicians. After the conference, multiple attendings approached me, some to congratulate me, others to share their own stories of near misses and diagnostic errors they'd made or witnessed. But the conversation that impacted me most came from Dr. James Torres, one of the senior internal medicine attendings. "Dr. Reyes, walk with me," he said, and we stepped out into the hallway. "I wanted to tell you something," he began. 20 years ago, when I was a second-year resident, I missed a case almost exactly like yours. Patient came in looking drunk, acting confused, combative. I did a cursory exam, decided he was intoxicated, and sent him home with a friend who promised to watch him. He died that night. Subdural hematoma. Nobody knew until the autopsy. I felt my chest tighten. "I'm sorry. I've carried that with me for 2 decades, Dr. Torres continued, his voice heavy with old grief. "It made me a better, more careful doctor, but it came at the cost of a man's life. A man who had a family, a job, people who loved him. A man I failed because I was tired, because I was busy, because I made assumptions." He stopped walking and turned to face me. "You just learned the same lesson I did, Dr. Reyes, but your patient lived. You got to see Gerald walk out of this hospital healthy. You get to know he'll walk his daughter down the aisle. That's a gift, not just for Gerald and his family, but for you. Learn from it. Remember it. Carry it with you. But don't let it paralyze you with fear. Let it make you more careful, more humble, more willing to question your own certainty." "I will," I promised. "Good. Now, I heard you're rotating through internal medicine with me next month. I'm looking forward to working with you." Gerald was discharged from the hospital 2 weeks after his surgery, with instructions for follow-up, physical therapy, and strict orders not to take any aspirin or blood thinners without approval from his neurosurgeon. His employer at Preston Building, after learning what had actually happened, sent a formal apology letter and offered him paid time off for his recovery. The termination paperwork was destroyed, and Gerald was welcomed back whenever he felt ready. He came by the hospital on his last day before discharge to find me. I was on a different rotation by then, working on the cardiology floor, but he tracked me down during my lunch break. He looked healthy. The bandages were gone, replaced by a healing surgical scar hidden beneath his hair. His color was good, his eyes clear and bright. He stood steady on his feet, no trace of the weakness that had been so prominent weeks earlier. "Dr. Reyes," he said, extending his hand. I shook it, feeling the firm grip of his handshake. No weakness, full strength restored. "I wanted to thank you in person," Gerald said. "Helen told me everything that happened that night, how everyone thought I was drunk, how you were the only one who kept looking." His voice caught with emotion. "How you saved my life. I just did what any doctor should do," I said. "No." His voice was firm. "Helen told me about the other doctor, about how he didn't want you to get the scan, how you insisted anyway. That's not what any doctor would do. That's what a great doctor does." He reached into his pocket and pulled out something small, wrapped in tissue paper. "I wanted to give you this. It's not much, but it means something to me." I unwrapped it carefully. Inside was a small medallion, worn and tarnished with age. On one side was the Serenity Prayer. On the other, engraved in small letters, 15 years. "That's my 15-year sobriety chip from AA," Gerald explained. "I got it last year. It represents the hardest thing I've ever done. Getting sober, staying sober, rebuilding my life. And that night when everyone assumed I'd thrown it all away, when everyone looked at me and saw a drunk..." He stopped, collecting himself. "You saw a person who needed help. You saw someone worth saving. That means more to me than you can possibly know." "Gerald, I can't take this," I said, trying to hand it back. "This is yours. This represents your achievement. And you gave me the chance to keep achieving," he said, gently pushing my hand back. "You gave me more years to add to that number. You gave me the chance to see my daughter get married, to maybe meet grandchildren someday, to grow old with Helen. Keep it. Remember that people are more than what they look like on their worst day." I closed my hand around the chip, feeling its weight, its significance. "Thank you, Gerald. I'll keep it always." He smiled, and in that smile I saw the man from the old photo in his wallet, younger, healthier, full of hope and second chances. "One more thing," Gerald said. "My daughter and her new husband, they're naming their first child after you. If it's a boy, Noah, they decided last week. They want to remember that someone looked at me and saw my humanity when everyone else saw trash to be swept aside." I couldn't speak. I just nodded, overwhelmed by the enormousness of it all. Gerald pulled me into a hug. Brief, firm, filled with genuine gratitude. And then he was gone, walking out of the hospital on his own power, heading back to his life, his family, his future. I stood in the corridor, holding his 15-year sobriety chip, thinking about how close we'd come to a completely different ending, how easily Gerald could have become another tragic story instead of a miracle recovery. The difference between those two outcomes was measured in subtle signs and small decisions. A reflex that bounced a little too forcefully, a pupil a millimeter too large, and a choice to trust instinct over authority. 3 months into my residency, I'd thought medicine was about memorizing facts and making quick decisions based on pattern recognition. Now, 6 months in, I understood it was about something deeper and more complex. It was about remaining curious when you think you know the answer. It was about seeing people, not just patients. It was about having the courage to question authority, even your own growing authority, when something doesn't feel right. It was about recognizing that every person on a gurney has a story, a family, a life worth fighting for. Gerald Morrison taught me that. He taught me that the most important diagnostic tool I have isn't in any textbook or laboratory or imaging suite. It's the willingness to pause, to question, to look at the person in front of me and ask, what am I missing? What story am I not hearing? What assumptions am I making that could be wrong? I put Gerald's sobriety chip in my white coat pocket, where I carry it every shift. Sometimes during long nights in the ER or difficult patient encounters, I reach in and feel its reassuring weight, reminding me why I'm here, reminding me to see people. Last week, 7 months after that night in the ER, I got another email from Helen. Gerald was back at work full-time, fully recovered, enjoying his new son-in-law, and already excited about becoming a grandfather someday. They were planning a big family vacation for the holidays, the first time they'd all been able to travel together in years. She attached several photos. Gerald at work, mopping a floor with a smile on his face, very much alive. Gerald and Helen at their daughter's wedding, dancing together. The whole family gathered for a Sunday dinner, 3 generations around a table. And one more photo that made me catch my breath, a positive pregnancy test, with a note that said, "Coming this summer, baby Noah Morrison. Thank you for making this miracle possible. Thank you for every moment we get with him," Helen's email said. "For every laugh, every holiday, every ordinary Tuesday night dinner around the table. For everything." I printed that last photo, the pregnancy test and the note, and added it to Gerald's 15-year chip in my locker at the hospital. Together, they represent something fundamental about why I chose this impossible, exhausting, sometimes heartbreaking profession. They're not just mementos of a patient I treated or a diagnosis I made. They're reminders of what we're fighting for every time we put on this white coat. Not perfect diagnoses or flawless clinical judgment. We're human. We'll make mistakes. We'll have moments of uncertainty and doubt. But the commitment to see people, to question our assumptions, to investigate when something doesn't add up, even if everyone else thinks we're wasting time or overreacting or being overly cautious. Because sometimes the difference between life and death is simply being willing to look twice. Sometimes the difference is refusing to accept the easy answer when the harder truth might save someone's life. And sometimes the most powerful thing we can do as doctors is to see someone that everyone else has overlooked, dismissed, or given up on, and decide they're worth our time, our attention, our thorough care. Gerald Morrison was worth it. Every patient is worth it. That's the lesson I carry with me every shift, every patient encounter, every diagnostic puzzle. And it's the lesson I'll carry for the rest of my career, however long that might be. Because in the end, medicine isn't about being right all the time. It's about caring enough to make sure you're not wrong about the things that matter most. It's about seeing the human being behind the symptoms, about remembering that every person in a hospital bed is someone's whole world, about fighting for them even when it's inconvenient, even when you're tired, even when authority says to stop looking. Gerald Morrison taught me that in one night, and in return, I gave him a future, a chance to see his daughter marry, to meet his grandson, to keep building his story instead of having it end on an ER floor because everyone saw what they expected to see instead of what was really there. Sometimes I think about all the Gerald Morrisons out there who weren't as lucky, the patients dismissed because they didn't fit expectations, who died because someone stopped looking too soon. We'll never know how many there are, but each one is a tragedy, a preventable loss, a family forever changed by assumptions and bias and premature closure. That's the weight we carry as physicians. The knowledge that our assumptions, our biases, our moments of certainty can have life or death consequences. It's humbling and terrifying and crucially important, but it's also what makes medicine meaningful. The chance to stand between someone and the worst day of their life. The privilege of being the person who looks twice when everyone else has looked away. The honor of seeing someone's humanity when the world has rendered them invisible. Gerald Morrison mattered. He mattered to his wife, to his children, to his future grandchild who will carry my name. He mattered enough to deserve a second look, a thorough exam, a CT scan that everyone thought was unnecessary. And in the end, he mattered enough that I was willing to risk looking foolish, to challenge my supervisor, to trust my instincts over experience and hierarchy and the easy answer. That's what I'll remember most from my first year of residency. Not the procedures I learned or the diagnoses I made or the medical knowledge I accumulated, but the night I learned that the most important skill in medicine is the willingness to see people, really see them, even when everyone else has stopped looking, especially when everyone else has stopped looking, because that's when it matters most. Sometimes heroes don't wear capes or badges. Sometimes they wear stethoscopes and white coats. Sometimes they're first-year residents with more questions than answers, more doubt than certainty. But they share one essential quality. They refuse to look away. They refuse to accept the easy answer. When a human life hangs in the balance, they see people, and in seeing them, they save them.